of the coalition. I'll mention that in just a moment. So thank you everyone for joining us for our monthly webinar for the Healthcare Coalition. We've been at it now since March, and we've had an amazing variety of speakers and topics. And this month, we're going to be discussing innovations in wastewater-based epidemiology for monitoring COVID. And we have an all-star lineup for you. Just wanted to mention that the coalition is going strong. We have a number of projects that are moved into very impressive stages of their development. And one of those is the Telehealth impact study. I just put into the chat a link to the study that was published this week on the c19hcc.org website. And also in that is the invitation for all of you who are participating today to take the survey. If you have been a patient in and had a telehealth visit since the beginning of the pandemic, and share that link with your family and friends and colleagues. Our goal is to get a few thousand replies from people that have had interviews, have had telehealth visits. That's just one of many projects that are underway with the coalition. Today, we're going to turn our attention to life in the university and in communities that have taken the opportunity to use a novel approach for SARS-CoV-2 monitoring. I'm going to hand the mic over to Kunal Rambia. He's going to introduce himself and talk about the work group that's rallied around this topic. And I think you'll be very impressed. We'll have a short presentation from each of 4 speakers, and then we'll have extended Q&A among the group. So Kunal, it's all yours.
Thank you so much, FX, and good afternoon to everyone. Thanks to FX and MJ for helping to organize this discussion. I'm really looking forward to it. Within the COVID-19 Healthcare Coalition, one of the themes that has been persistent in our minds is situational awareness. How do we know the extent to which COVID-19 is affecting our communities? And without that knowledge, and in the context of all the challenges that have been associated with individual diagnostic testing, we're asking and expecting our leaders to make important decisions that impact lives using incomplete data. And while they may continue to be in that position for some time, we have made incredible progress as a country in the ways that we track SARS-CoV-2 using wastewater-based epidemiology. So in the late spring, the coalition became very interested in the value that wastewater-based epi could have as an operational tool to provide both an early warning and ongoing situational awareness. We partnered with the Oak Ridge Associated Universities, ORAU, this summer to share lessons and understand the state of practice on this topic. And of course, Dr. Dadler was part of that seminar and that we hosted with ORAU in July. So we're glad to have her join us today and hear an update on what she's been doing. We're continuing to work with a range of academic partners and private sector partners, including the START Coalition and others, to raise awareness, share information, and accelerate the development and application of wastewater-based epi. And what we've seen in this field is a rapidly evolving technology, as well as an increased reach of this technology. The panel that we've assembled today has a wealth of expertise and experience, and we're very excited to have this conversation about how wastewater-based epidemiology is being applied within facilities like prisons, schools, or nursing homes, within campuses and across communities. So we'll hear some terrific examples of how these efforts provide leaders at all levels with actionable information to protect their communities. And the story on wastewater-based epi is still being written, of course. So I'm particularly interested to understand from our colleagues what still needs to be done to realize the full potential of this approach, and how this coalition and the community here might help support the goal of building a robust sense of situational awareness in this pandemic for now to deal with COVID-19, but also for future public health purposes. So with that, I will ask Dr. Birthe Kjellerup to lead off our conversation. And after we hear from our panelists, we would like to have a true conversation. So please feel free to ask questions in the chat and we will get to as many as possible. So thank you, and Birthe, can you please take it away?
Thank you very much. It's my pleasure to be here. I am an associate professor at University of Maryland at College Park. And we have, as a group from campus, worked on this approach with COVID-19 environmental monitoring, not only in wastewater, but also in other environments, as you will see. So on campus, at the UMD campus, we have had multiple conversations for the past many, many months, and I would imagine many of you have had similar. And what we have learned already so far is that it is very, very important to have a broad coalition of members from campus involved in this work. And I will just mention some of the ones that we have in this group of environmental monitoring in University of Maryland. We have the University Health Center, Administration and Finance, Facilities Management, Residential Facilities, Environmental Safety, Sustainability and Risk, Student Affairs, the General Counsel, Mechanical Engineering, School of Public Health, and Civil and Environmental Engineering, which I'm from. So the last three have the faculty doing the actual monitoring, whereas we are interacting with these many other people to learn the best we can and help each other out. And I will say the success of the program that we are running is relying on all being involved and being interested in communicating and thinking outside the box, because we haven't experienced this before, and campus is for sure not set up in either above ground or underground, as we have learned also. University of Maryland, our goal of the environmental monitoring program is to assist our campus community to the largest degree possible to provide early warning for COVID, for instance, as mentioned in the wastewater, but also to follow up on activities that are happening. And a large part of this comes down to the fact that early on there wasn't enough testing available in the community. Our program was initiated in August 2020 before the students arrived for the fall semester. It includes what we call high-touch surfaces. So outside door handles at dorms, dining halls. It's also indoor exercise areas and some academic building surfaces as well. It also includes air sampling. That has mainly been done at indoor exercise areas and dining area pickup, since indoor dining has not taken place this fall at campus. And then wastewater, where we're currently using 6 auto samplers put up in communities where we're monitoring wastewater for 200 to 2,000 students. And I'll come back to a little bit of our experiences there and what's moving on. Just short on the results so far, without getting into numbers, our 3 methods have complemented each other very nicely, and the results are also corresponding. We are continuing with the wastewater part at this point, mainly because our local COVID numbers in Prince George County in Maryland, the numbers are going up. So it has been decided that the students will continue all courses online, and they have been advised to the degree possible to return to their homes. But I just learned that about 2,000 students will still be back at campus for the rest of the semester and winter break. With those students in mind and the return of the students in whichever form, which remains to be decided for the spring semester, we are changing gears a little bit on the wastewater and going into building level monitoring. So we will spend the winter break to set this system up so we can specifically monitor from dorms, specific halls, and so on, to get an increased granularity of the information, because 2,000 students in a residence it's not providing us sufficient information that's helpful for the health center. We will expand our monitoring also to academic and administrative buildings in the spring as we learn more about this, so we can assist in the testing effort and make sure that our students and staff, also everybody in the campus community, will be safe. We are working closely together also with School of Public Health that have different testing. So we're talking human testing options up for consideration that would be able to help us in this effort as well. So I will stop here for now, and I'll be happy to take questions later on. Thank you.
Thanks so much, Birthe. I think you described quite the coalition of partners, and I'm sure that there are several questions, but let's continue on and we'll come back to the discussion in a little bit. But I'd like to ask Dr. Shane Rogers from Clarkson University to take the mic.
Sure, thank you. Now I'll just share a little bit of what I put together and try to keep it kind of brief also. And so just to give a little background of who I am, I'm at Clarkson University. I'm an associate professor of civil and environmental engineering. I came here by way of the U.S. Environmental Protection Agency, who I worked with as an environmental engineer and then a special government employee for a number of years. And you know, when this outbreak took place, when it started, it became apparent that I may be able to apply some of that expertise to with wastewater-based epidemiology, which was growing very fast in response to the COVID crisis. And so we started our programs here. And so I'm just going to share with you a little bit about what we do. I'd echo Birthe's comments on the need for integration among the campus community, or more broadly. We've had a very similar experience here, where we've had facilities, we've had our administrative staff, we've had people from different groups on campus. At Clarkson, we're very fortunate with a very technical group in engineering. We're a small private university, but we do have quite a bit of expertise across different areas of engineering. And part of that is a group that's very well-versed in computational fluid dynamics, air modeling and sampling, also doing work with bioaerosols and in detection and movement and those sorts of things. And so tapping into all of those resources here, we were able to put together plans where we could do computational fluid dynamics models of each of our classrooms, for instance, to understand where dead spots were within the institution, and how to arrange the desks in the most appropriate way to reduce probability of particles, aggregating where students were seated, and other efforts that we've done on campus. And I'll focus a little bit because I've been working with the wastewater-based epidemiology. That's where I like to focus when I talk about what we're doing here. And so with that, we are in a fairly isolated region up here in the North Country of New York, north of the Adirondack Mountains. With the border closing to Canada, our nearest city would be Syracuse, which is about 2.5 to 3 hours drive away from here. Normally it would be Ottawa within an hour. We do have a number of institutions that are up here, a number of universities, and along our what we call the Clarkson corridor throughout New York State, which you can see here from our main campus down through the Trudeau Institute, which is now part of Clarkson University, the Capital Region campus near Albany, in Schenectady, the Beacon campus closer to the city, and then in New York City we now have Pier 26, where we're building out some activities there as well. And through what we've been doing, we've had other universities express interest in wastewater-based epidemiology and approach us for our assistance where they don't have that technical expertise on their campus. And so we have picked up and are assisting with wastewater-based epidemiology with SUNY Canton, St. Lawrence University, both the village of Potsdam and the village of Canton, where our universities are at, of course, Clarkson University. We've recently picked up the Culinary Institute of America near our Beacon campus, who will begin monitoring next month. And University at Albany, we've been providing assistance in regard to identifying sampling locations within their sewer system and in getting their analytical capabilities up and running and making decisions on how they might do that. But they have their own analytical facilities and are capable of doing that on their own. We're also sampling a middle school, the North Country School in Lake Placid, to assist with determining whether the virus will emerge or would emerge on their facilities. I like to think of this, someone had mentioned this to me, it's kind of like one of my students, kind of like looking through the trash and seeing what you can find. And so I like to think of it that way now. It's kind of a funny way to think about doing wastewater, but there is quite a bit of information in there. And we're fortunate that this virus can be detected in wastewater. What we're doing is basically bringing, when we bring in a partner, bringing the full suite of capabilities to them. So helping, like I said, assist with identifying where things are in their, within their sewer system, where might be likely spots for different samplers and what the limitations might be of those so that they can make informed decisions on what to do. Setting up sampling equipment on the sewer network and getting the programming in place through analytical testing and also providing interpretation for the results so that they can make informed decisions on each of their campuses. Of course, with that, we're integrated with the different COVID response teams on each of the institutions that we work with so that we can provide information that's useful and assure that they're understanding the information that we're providing to make the best decisions that they can. Just to give a quick example of what one of those systems might look like, just so so those here who are not too familiar with the way this works can see some of the nuts and bolts. This is what we have on our own campus, and you can see that we've selected 7 different sampling locations that we monitor frequently, and those locations aren't necessarily individualized for a single residence facility. We've done our best to limit the number of students within each sampler, but yet the way our sewer network works, there are some sampling locations that are intercepting flow from sampling locations, we say up sewer, from those access points. And so that presents a little bit of a challenge. It was a little bit of a concern coming into our testing, but at the same time, we've been able to sort some of those things out. So just saving some of that for later in discussion, I'll just show you an example of where one of these exists between one of our residence facilities, we call it Price Graham and Morehouse, and then the quad down sewer from there. You can see in this example where we had students moved. We have Price Hall is our quarantine dorm. We had students move into quarantine into the dormitory. We see, a spike in concentrations of N1 and N2, which are genetic indicators of the virus. During that time, the students are in quarantine. Then the students were released from quarantine after their infection subsided, but they were still shedding the virus, which is common. And we were able to pick them up as they moved back into the quad after that time period. And then, of course, we have another a period of time recently where we had a couple students, again, move into quarantine. We start picking up the virus markers there again, and we can see down in the sewer network, down network from where that quarantine dorm is, we do see little bumps that occur from the higher concentrations here. The reason why they're not as high is because of the dilution effect that occurs from all the students that are living in here, the kitchen facilities, the showers, and other things that happen in between sampling point number 2 and point number 6. And so we've been able to effectively, while keeping track of sewer dynamics, we've been able to effectively isolate, even in the same sewer network, differences from one point to another. Just a couple last quick points before I turn it over. Some community interests and needs have emerged from this. I'd speak to a large number of people and try to provide help where needed. We have in our North Country several different K-12 institutions where we've had issues with a student in the institution who comes up positive, or a small set of students, and then because they don't have access to testing programs, of course, have issues the response, whereby they have to often close the schools for a 2-week period or more to deal with the potential spread in the institutions. And so they've had interest in being able to apply wastewater-based epidemiology to reduce some of the vagaries that they have when they do have a student that shows positive. You know, the vagaries being, did it spread within here? Are we seeing signs of other infections? And because of that, they have to take the most extreme measures that they can. And of course, I'll be happy to talk about some of their limitations. Similar at nursing facilities in the area, you know, some of the limitations being costs and ability to track those, but a lot of interest within the nursing facilities up here. And then, of course, education and student integration, where here at Clarkson, I've been very fortunate to be able to integrate this very fully with our students in my wastewater engineering course and provide education on wastewater-based epidemiology for the next generation of students. And so we really do need to be, as we're thinking about reinvesting in our infrastructure, you know, thinking about how we prepare our students, you know, so that they can design these into our wastewater systems so that we will be prepared for the next outbreak that may occur. With that, I'll just turn it over.
Thank you, Shane. You raised a number of interesting points about the potential for growth of this field, some issues related to sampling, as well as the need for collaboration, which I think is, you know, one of the major positives that we've seen is how much collaboration is happening around this. So hopefully we'll come back to that in the discussion. But I'd like to now ask Dr. Lawrence Dadler from Rice University to join us.
Here we go. Okay, thank you so much for the invitation to be here today and to kind of share an update of the work that we've been doing here in Houston using wastewater-based epidemiology to track community infection dynamics in our communities here in Houston. So we've been working really closely with our health department here in Houston to implement this, and this has been a collaborative effort between Rice and also Baylor College of Medicine. Oops. There we go. So just as an overview, oops. Okay, let me make sure I have this timing. No, it's not done. Okay. Apologies for that. So just as an overview, what we've been doing since early May is to collect wastewater from 39 wastewater treatment plants that we have here in Houston. These samples are collected every single week. They're 24-hour composites, and then they're split between 2 independent labs, my lab here at Rice, and then the Taylor lab at Baylor College of Medicine, where we each analyze these samples in replicates. And then the results are fed into a statistical model that we've developed and then sent back to the health department. And the entire process takes about 3 days of active time. So these 24-hour composites are taken Monday to Tuesday. We analyze them Tuesday to Thursday, and then we have results by Friday. And certainly this pipeline could be, I think we could make it faster just by increasing throughput. And so we started to think about that, especially as we've had discussions about expanding. So just to kind of show a few of our results and how they're being used. So we started this in May, and here I'm showing a map of the population normalized virus levels in all the 39 sites across Houston. And so every week we basically deliver a report to the health department that both has two important pieces of information, or 2 primary pieces of information. One is this population normalized virus level to give a sense of impact in each of the communities. And then the second is the trend or the change from the previous week. So that's basically the difference from one of these maps to the next for each of the sewer sheds that we've been looking at. And then the health department uses that information every week to basically prioritize, along with a lot of other health information they have on these communities, where to go and send strike teams. And so these are people who actually go into these communities and provide information about local testing facilities and information about how to stop the spread, like mask wearing and other best practices. And as you can see, if you look back to May and June, we were clearly experiencing, this is kind of the heart of the surge. And since then, things have gotten quite a bit better, though we do see, I haven't shown the November data here, but we do see it start to pick up here in Houston in the most recent weeks. And we feel really confident, and the health department feels very confident in using this wastewater data now. And it took some time, it took a long time to build the confidence that we currently have in the data that we're producing every week. And that's a combination of the fact that we rapidly developed the methods to do all this and to do it at scale, across 2 different laboratories. And second, to basically to amass this amount of longitudinal data that gives us the confidence that this is a potentially predictive measure of case positivity in our communities. So here I'm showing on the left, basically just a plot that shows the wastewater viral load. So this is the concentration of the virus that we're measuring times the flow rate for all the facilities that we've been sampling since early May. And the gray is just the 95% confidence interval around those measurements. And then the blue lines, or the blue X's, are the positivity rate for Houston over the same period. So that's the number of positive tests divided by the total number of tests. And what you can see is that the wastewater and the positivity rate data are extremely highly correlated. And we also did a cross-correlation analysis that basically told us that the wastewater data can actually lead the positivity rate by about 2 weeks. And then here on the right, I'm showing over the entire study period. So each one of these triangles represents an individual treatment plant that we've been measuring at. And each triangle represents the total viral load that we've measured over this time, the 23 weeks we've been measuring, plotted against the total number of positive cases in that sewer shed. And the only difference between the green and the red is the green are the sites we've measured since early May, and the red are the sites that we started measuring in early July. But this is just very compelling to us because we see this very strong relationship between total positive cases and total viral load all the way across Houston. And we do this at the individual sewer shed level as well. So here I'm just showing 6 different wastewater treatment plants that vary in size and total population served. And we can see that we see these strong correlations between our wastewater viral load shown in green and our positivity rate shown in blue. And this is robust across treatment plants that serve 500,000 people to those that serve much smaller communities. And then finally, to talk a little bit about what we're trying to do now, because we've observed such a strong correlation between our wastewater viral load data and the positivity rate, we want to now use wastewater viral load information to predict positivity rates in communities or predict infection burden in communities. So we're working on building these predictive models or forecasting models where you actually use the wastewater data to predict positivity rates 2 weeks in advance in communities. So here I'm showing a model that was built using the longitudinal data that we have amassed over the past 23 weeks at these 39 treatment sites. And it basically predicts the positivity rate using the current and 2 weeks previous viral load data and information about the wastewater treatment plant that came from. And then it uses it to predict 2 weeks in advance future positivity rates. And so here I'm showing that these are all the predicted positivity rates using this model plotted against the actual smooth positivity rates in each of these sewer sheds. And we see a very strong predictive power using this model. And these 2 graphs on the right are actually just showing kind of the output of the model. So here, the blue line is the output of this, where we actually use this wastewater viral load data, predict positivity rates, and plotted that over the actual positivity rate in that sewer shed. So that's shown in the gray. So each of the circles is an actual positivity rate, a daily positivity rate, and the black line or the gray line under it is the smooth positivity rate. And then these 2 purple dots are kind of the forecast for 2 weeks in advance. 2 weeks ahead of time. And again, this is something the health department's extremely interested in. There's huge limitations, of course, to the case data and to the positivity rate data, especially in some of these communities where we have very messy or a limited positivity rate data. So we picked this example because you can see like the positivity rate is all over the place, and that's because Some days there's a lot of people getting tested, and other days there's very few people getting tested to the point where we can't even really, calculate a positivity rate because there's so few tests in this community. And so they're turning to wastewater-based epidemiology to kind of get a better sense or a primary sense of the infection burden in these communities. And moving forward, we're just thinking that it's expanding thanks to the success of this so far, and we're looking at monitoring more vulnerable populations. So just the past few weeks, samplers have gone in at 60 schools and high positivity rate areas, 15 nursing homes, and we've been monitoring a jail and some homeless shelters also in Houston. And a lot of this work is shown in this preprint we recently put out, but I'd be happy to chat more and answer questions. Thanks.
Thank you so much, Lauren. Raised a number of great issues and showed really impressive data. Both, I think, one of the important things that you showed is that it takes time to build confidence in that data. So I'd like to come back to that issue, as well as some of the other opportunities to expand the work that you just presented on that last slide. But let's go ahead with Dr. Ted Smith from University of Louisville. And then once Ted's done, we'll kick off the question and answer. Go ahead, Ted. Thanks.
Great. Thank you so much for having me today. So I love following Dr. Stadler because I think one of the most important things for us to keep track of is the quality of the clinical data that is available in the United States. And our project starts in a slightly different place. So we start with a comprehensive view of prevalence. And so this is an epidemiological project. It's not an environmental monitoring project. So we are trying to understand the prevalence of infection in Louisville, Kentucky, which is a consolidated city county of about 750,000 people. And so the co-immunity project, it has three parts to it. The first two pieces, surveillance of active infection and surveillance of past infection, we execute through random sampling of the public. And then the third piece is what I like to think of as Holy Grail, which is how do we understand what shedding rates in feces, how they comport with a gold standard estimate of clinical prevalence. And so that's the co-immunity project. It's funded by the CARES Act. This is part of the city of Louisville's testing program. There are three parts to the testing program. Obviously, the city tests symptomatic people. The city has a focus on high risk asymptomatic people, so meatpacking plants and vulnerable populations and congregate living settings. And then the third phase of the city strategy is to have a regular prevalence assessment that's geographically partitioned. And so just quickly to give you a sense of how you can back into a good epidemiological framework for wastewater, you would start with how would you understand the community that you're surveilling? And again, here I'm talking about whole communities. I'm not talking about congregate living facilities. And in our case, we partnered with WestStat, which is the federal government's contract research organization for many of the national cohorts for disease burden. And we came up with many, call it bins of demographics across our community. And that would form the basis of a stratified random sampling strategy. I'm not going to go into the details, but it's a multi-stage stratification. So what we want to have at the end of the sampling is reliable statistical estimates by age, by race, by sex of what infection is in the community, both current infection and past infection. And so here are results. We do this every 8 weeks. These are the results from September. We just finished another wave that we don't have all the results in right now. But for example, in this wave, we physical mailed 32,000 people that sort of drawn out of a hat in each of these bins, an invitation to be tested. We had 1,500 people respond to that invitation. We also accommodated another 600 people on a convenience sample basis, so we can start to understand the gap between people who seek testing and people who are randomly chosen for testing. So, we tested about 2,200 people on an active infection basis. About 0.74% were actively infected on the week of testing, and a large 4.4% of people, had antibodies for COVID. And so, what that helps us do then immediately is take a look, just as a simple exercise. We could estimate that 34,000 people in Louisville have been infected since inception, since the beginning of testing. We only have records at the health department for 17,000 people because of all of the oddities related to testing. And so, as you can probably guess, we are significantly undercounting primarily asymptomatic people with this clinical testing framework we have in the United States right now. So this method is important if you want to truly back into wastewater, because we have to have a true comparison, because we believe that the wastewater is a true prevalence assessment. Just quickly, we think it's important that we try not to mix up our frameworks for EPI. So, there's a real dynamic that's pretty well demonstrated in congregate living, whether that's in dormitories or prisons or homeless shelters or whatever that may be. Then there's the work that Dr. Stadler just presented, that we do here too, which is focused on a whole sections of communities. And then, of course, as you know, the whole thing in large part in the United States was built off of wastewater treatment plants for entire communities. And so we've seen these three levels of abstraction. And one of our great frustrations is when these things get confused with one another, because they're different epidemiological frames and they have different analysis requirements. And just so you can see, so we've taken our random sampling framework, we've overlaid that against the sanitary sewer system, and we've come up with catchment areas that fit within each of the major bins of the random sampling. We sample there twice a week, and we've been doing that since the beginning of July. We have a lot of data for each of these individual sewer sheds. I'm sharing with you here, we aggregate these into zones. The mayor's office then works with the rest of public health and their response team to go out to these parts of the communities, similar to the Houston scenario, where we are targeting enforcement and communications in areas that have the highest total viral loads and the highest growth week over week in any particular period. One of the interesting learnings that we've had out of this work to date is the remarkable difference at these different levels of abstraction. And so we're at the point now where we actually don't see much value at the wastewater treatment plant level if you can get the next level of granularity down. And I share with you just an example of how badly averaged out or diluted or degraded a wastewater treatment reading can be compared to a contributing catchment area. And here, one of our most vulnerable communities is entirely missed if we go to the wastewater treatment plant that it feeds, when we can see, it would be in this particular window, one of the most problematic areas in our community. And so we're really trying to get a handle on these scalar properties in wastewater-based epidemiology and how important that is. And then, just quickly, we're all sort of chasing the same thing. How do we truly estimate the number of cases or the extent of transmission based on these signals? Obviously, we're trying to back it into our randomized stratified sampling as a gold standard measure for coming up with that. Thank you very much.
Thanks so much, Ted. I think this issue of the clinical data versus the wastewater data is such an important one. And one thing that we talked about as we were preparing for this panel was just exactly that issue. So maybe I'll start with a question and then encourage others to chime in here with questions on the chat. But if I can ask Birthe, Shane, and Lauren also to turn their cameras back on. And FX, please also jump in here if you've got questions you want to pose to the group. But just wanted to start with one specifically related to this issue of clinical data versus wastewater data. Lauren, you presented some interesting findings that show that 2-week early warning that you were able to determine, but also talked about building trust in that data. And Ted, I think your approach to use the random sampling to build trust within that data is also quite important. Does anyone on the panel want to comment on just that ability to get better at assessing what's in the wastewater and how it translates clinically, or vice versa?
I mean, I think the single biggest challenge we have is the very large number of asymptomatic or pre-symptomatic shedders that are in the population. And I think we now have much better clinical data than we had 6 months ago, and it is a large number of people that are actively infected who are subclinical or don't notice for whatever reason, and they are truly missed in these other methods of testing. And this is why I like to believe that wastewater is actually the standard, and then we're trying to catch up to a degraded sample in the clinical.
I'll just add to that and say that I very much agree. And we increasingly, like, at first we were a little questioning about how much we could really get out of the wastewater data. And since through the evolution of this project, we've really switched to taking that thought of like the wastewater is probably more representative of what's going on in our communities than our clinical test data. And there's just a whole host of problems with the clinical data. And we've been really lucky in Houston to have the full partnership of our health department in this. So for example, like our positivity rate data that we're getting to compare our wastewater data has been cleaned like very carefully. Like every single data point has been cleaned for us to allow us to do the analysis. So one example I'd like to give on this is when clinical data often has repeat tests, for example. So like if I'm sick, I might get tested once, tested again. Some people get tested again and again until I'm negative, right? And if you're trying to compare that to your wastewater data, you probably actually don't want to include all the repeat tests of people who've been tested multiple times positive as individual new positive cases, because that's going to obscure this relationship. So we have had so if you, for example, if you go download the data from these like publicly available sites, it doesn't have the data cleaned that way. So every positive test, even if someone's been repeat tested, is reported. And I asked our health department, like, what % of these positives are repeats? And I think I got a number, about 80% of the positive counts are for repeat individuals. So that means like, that is a huge amount. And it's because everyone's getting tested about 1.5 times, it turns out. So, and there's a few outliers that are probably getting tested a lot more. So I guess the point being that like the positivity rate data is messy. It's super messy, right? And
yeah, absolutely. I think it's important for us to continue to have that discussion across the different groups here. As you guys mentioned, as you all mentioned, there's this need to have buy-in. You have it, Lauren, with the Houston City Health Department, and I think all the folks here on the call have built that relationship. Just to kind of piggyback on this conversation and picking a question out of the chat here on the turnaround time. I think we're all kind of interested in how quickly do we get these results to leaders, and how important is that turnaround time? Can you all speak to what's been successful or what's been challenging with respect to the turnaround time? Maybe I'll ask Birthe and Shane to chime in here first, and then if Lauren and Ted have any thoughts on that.
So we have set up our program so we try to collect samples from times where we think the students will be in their dorms and also over weekends and so on, so we can get the samples processed and get the results back to the health center in case action needed to be taken before a weekend or before a big event or something like that. So we are currently collecting over a 48-hour period composite samples, analyzing and getting the results out the following day, so we can get action on what we're doing, because otherwise it is not providing much help. Then it's after the fact, and we can just correlate with what has been found. It's not helping us to put other measures in place in case a specific residence hall needs to quarantine or something like that to avoid spread. So I think what our experience is that it has to be coordinated. When are you sampling? How long are you sampling for? How fast can you analyze? How fast can you get the results to whoever needs the results? And how can they then react? So that is where we have come to now, that we can actually help each other move these parts around so it becomes useful.
Thanks, Birthe.
I would just add to that there are some differences between one lab to another that often can affect the speed at which the samples can be processed and the results. returned to be actionable. And some of those differences could be, for example, size of the facilities at different institutions that may be employing this, and the amount of throughput that they can work with, how much automation they may have within their processing chain. A really large area where it can, a bottleneck that you may have is actually in the sample concentration step for processing these samples. And depending on what a laboratory may have available, what their experience is in doing the sample concentration, which generally it seems to be best to keep with your experience on these, you know, that can change your processing time from hours to sometimes days, depending on what you're using for that concentration step, or a day or more. And so where some labs might be able to turn around a result after it's been sent to the lab within, you know, hours, you know, if we get one in, we can go as short as, you know, 10 to 12 hours after we get a sample returned to us and get an answer out. That's not common. You know, other facilities are looking on maybe a day to 2 days to get an exam, for example, to get an answer out. And so, you know, in terms of what we're doing for sampling, we've been doing twice a week sampling at the institutions that we're monitoring, 24-hour composites to try to capture. Most people are regular. The median regularity of people is within the 24-hour period, 24-hour window. And so we chose 24 hours for that twice a week so that we could also stay on the leading edge of what might be emerging, where an objective like on a campus or in an institution may be to stay ahead of things versus trying to monitor whether things are going up or down within a community. So all those things can have an effect on how that plays out if you're considering doing this on your own campus.
Thanks, Shane. Anything else from Ted or Lauren on that one?
I just want to make a comment that, you know, I'm very hopeful that as this matures as a science and a public health practice, that we'll do exactly what we did with human clinical testing, which is a commercial sector will emerge. So we've spent the last 2 months getting Eurofins cross-trained against our methods. So that's a commercial laboratory. They work 7 days a week at 3 shifts. They turn around samples across the region in 48 hours. And so that's our goal, is to get out of the business as an academic laboratory and doing this routine work, and essentially get a commercial sector spun up, just like Quest and LabCorp, but for this kind of work, reliably with transparency.
Great observation, Lauren.
Yeah, I was just going to say, you know, I feel like because we've scaled pretty fast that it in some ways my lab has had to try to operate more like a commercial laboratory, in which I have no experience in, right? But our goal in Houston is to get our health department laboratories, which are doing clinical tests, to basically take over the analysis work. So a similar approach, not with the company, but with the Houston Health Department laboratories. I think the health departments really wanted academic partners involved right now, because they do see that the methods are evolving, and we are doing a lot of method development on the side. And so like every data point that we collect every week, we also have like a bunch of side method evaluations. And as we learn more, we bring that into our pipeline. And so I think because it's not quite settled in terms of approaches, not just for concentration or extraction, extraction and quantification, but even like, how do you preserve samples? How do you, what's the best way to store samples, all that stuff. They've really wanted us to be involved so that we can continue to work on the side on these method development issues.
Wonderful.
This is FX. I had a question regarding the testing. There's a lot of interest in understanding the fidelity of it and this idea of live versus killed virus. Is there any opportunity to do a combination of genetic testing and biomarker testing to give you ratios that would help you know whether there's live or dead virus in the community? Would that be useful in your interpretation?
I personally don't think it would be all that useful. I know there are folks who are concerned about things like combined sewer overflow and recreational waterways who are concerned about the viability of live virus, being present. But I think for the epidemiological mission, that's not something that we've been focused on.
So,
I was going to add, I think the only way we thought it might be relevant, and that this maybe is that if, for example, and this is maybe a little bit outside, but like if you had an infection of your GI tract, right, which they've shown now that SARS-CoV-2 can also infect your gastrointestinal tract, that might be a relevant piece of information because it would impact potentially how you interpret the wastewater results. But I think right now there's not a whole lot of evidence to support that. I think from a worker safety perspective, certainly our utilities are very interested in knowing the answer to that question.
Great. So let's take a question here from the chat. Hallie Reeves from Oklahoma University, really interested in issues of scale. What are the implications of measuring concentrations in wastewater from a sampling site that represent 40,000 compared to a sampling site that represents 100 people? So we have various scales that you've discussed so far in your various projects. So hoping you can address Hallie's question as a group.
I think it gets easier as the numbers get smaller. We get more confidence over exactly what we're doing. So it's a rough heuristic. So smaller, better for getting some certainty about what the situation is.
I would just add that at least what we've seen is our smaller sites tend to be noisier though as well. So we might see, for example, like a sharp increase, but that the next week will come way back down, and that like sometimes our 1 week trends are less consistent with our overall trends at our smaller sites than at our much larger sites. So which would make sense just in that there's going to be more noise in these smaller communities than in the bigger, huge treatment plants.
Adding on to that, I've had the similar experience looking at the community scale at 8,000 to 10,000 people, but then also at the university scale where we're looking at just a few hundred students or less in a particular sampling point. And the one thing about the small sampling points is that they're very subject to transient activity. So we ask the students not to bring guests into their dorms. Whether they actually do that or not, it's hard to say. And so you may get something that shows up and where did this come from? And, and it goes away. And so that noise it can be tricky sometimes as you're trying to interpret the data and make recommendations on it at the small scale, where it might smooth out a little bit, I think, at the larger scale.
So related question in the chat, roughly how many individuals normalized to the total population results in the lowest detected peak, for example, shown in one of the graphs as 0.5 copies per mil. Is there, I don't know if, I think this was directed at Shane or Lauren, if you could address that.
Yeah, I think that came out of my plot. We were able to detect a single student that's positive in a group of about 400 that might be residing in a dormitory. And we know that very specifically because we have quarantine dorms for when students go in, and we have a testing program, individualized testing program. And so we can combine those two pieces of information and be able to come up with those types of results.
We don't really know what ours is, to be totally honest. And I think also, at least for Houston, there's been positive people and across all of the sewer sheds over the entire period we've been measuring. So, and we don't know the asymptomatic fraction, but we haven't tried to do this calculation where we tried to see when you hit our limited detection for each sewer shed, because it can be highly dependent on the size of the sewer shed and the degree of dilution. The limited detection will be a function of that as well.
Great, thanks. So another question from the chat, and I think this one, trying to zoom out a little bit and think about what Ted had mentioned in terms of the future of this field. As this moves, and if this moves towards a more commercial or private sector effort, what do you see as the role of the federal government in supporting this endeavor?
Well, my personal opinion is, as long as we're in the middle of a national health crisis and pandemic, the role of the federal government, needs to be supportive of investing in the capabilities to help us combat the pandemic. As we move to, let's call it a more steady state, recovered version, I think most of us have learned the lesson who deal with the sanitary infrastructure. It wasn't designed for this mission, absolutely was not designed to do this work. There are all sorts of problems relying on this infrastructure to be the same grade test frame that clinical testing is in hospitals and other settings. So, we've revealed a pretty big gap in this infrastructure's ability to do this job for the healthcare system. And so my personal passion at the moment is upgrading this critical infrastructure, which I think is going to require the federal government and some state leadership to get an informatics layer and, kind of a better access environment and monitor environment than we have today.
Can I add to that too? So some of, besides working on with the surveillance at the campus level, I'm also involved in a working group for Maryland Department of Environment, and some of the counties in Maryland see that when it's raining, the infiltration rate is ruining all of their monitoring data because it's so diluted. They can see that there are cases in the community after a couple of days, but the infiltration is diluting it so much that the strategy is not working. So that goes to the improvement of the infrastructure itself. So there are many other aspects related to this than just simply clinical testing, public health, and so on. So as an environmental engineer, I see a big role for government involved in this moving forward.
Thanks, Birthe. We'll continue on. I think there's another question along the same vein in terms of the future of this field. Are any of the panelists at this time planning to include testing for influenza virus in their sewer samples that they're collecting?
Yes, we've begun that work already. It's at the earliest stages because it complicated the assays that we're running, but yes, we're doing that now.
We are also planning on doing that. We've not spun it up yet, but our health department's diagnostic assay that they're going to use initially to run the wastewater samples also includes influenza. So we will get that piece of information as well.
Great. So hopefully that's something that we can come back to in a future seminar is to address the utility across other pathogens and other uses for this. Wanted to also, there's another question in the chat here about the quantitative models that you're using. There was a question, do the models for wastewater analysis try to correct for the dilution, other effects of rainfall runoff, or is that variable additional flow volume insignificant? At least in Houston, I assume that variation of rainfall can be significant. So I know that Birthe, you just mentioned this as well, but Lauren and Birthe, is there are there other responses you provide to that question?
This is a great question. So yeah, we've been grappling with this a little bit. I guess the way we calculate what we present every week is a viral load. So what that is a concentration times the flow rate. And again, we're making some assumptions here, of course, but like the idea would be that if it were significantly diluted due to infiltration and inflow, that would be captured in the flow. So the decrease in concentration would be balanced out by the increase in the flow. And so we've started to look, we haven't had that many days where we've actually had an extreme rainfall event on a day that we are collecting a 24-hour sampling, but we have started to look at that a bit. And so far, I feel like that's the best we can, what we feel most comfortable doing right now. We're also doing some hydraulic modeling to actually estimate how much infiltration and inflow would occur given a rain event. But I am very interested to learn how other people are dealing with this problem.
So we've settled on 3 other fecal biomarkers. So we use the pepper model virus, we use cross-assembly phage and RNase-P. And all 3 of those are perfectly related to flow rate and help us do per capita adjustments for contribution, because I think we all know that the shedding rate is one variable, and then dilution is another variable. And we find these other fecal markers to be really useful adjustment factors.
So I know that we could probably continue this conversation for several more hours, but since we are approaching the top of the end of our session here, I did want to make note of two things. One, Anna Grace Alvarado had mentioned in the chat, there's a link to a site that captures all the dashboards that are producing wastewater-based epi data. So I welcome everyone to take a look at that. And Dr. Rolf Halden has also mentioned that Arizona State has been monitoring flu in their wastewater samples since 2019. So another good data point that we can come back to at a later date. But I really want to express our appreciation for the four panelists today, and really for providing such an in-depth discussion of this topic, and appreciative for the work as some of the leaders in our pandemic's response. FX, I will pass it back over to you as we wrap up.
Great. Thank you, Kunal. Thank you to the whole panel. It was absolutely fascinating. And thank you for this really important work. I'm hoping that it'll become the norm across many communities. Wanted to let you know that our next webinar will be on Wednesday, December 16th. So it's the third Wednesday of the month, same time, 2:30 Eastern. And we will be addressing social inequities as it relates to COVID-19. In January, we're going to continue, and the third Wednesday of January, we'll be focusing on vaccines. So thank you all, and I wish everyone a safe and healthy Thanksgiving.
Thanks.
Thank you.
Thank you.